Have you ever wondered what exactly happens when the heart's perfectly synchronized electrical system gets hijacked by pure, unadulterated chaos? Welcome to The Explainer. Today, we're diving into a fascinating and, let's be real, slightly terrifying medical detective story into the exact mechanisms of sudden cardiac arrest. We're going to uncover how tiny cellular glitches and microscopic structural changes can completely short-circuit the human heart. Here's our roadmap for today. We'll kick things off by defining these electrical storms. Then look into triggers like acute ischemia, long QT, Brugada syndrome, and hypertrophic cardiomyopathy. And finally, we'll wrap up with life-saving management.
Section 1. The electrical storm, chaotic rhythms.
Before we track down our culprits, we've got to define the actual rhythms we're hunting. First up is polymorphic ventricular tachycardia, or polymorphic VT. Normally, the QRS complex, that big spike showing the main pumping chamber squeezing, looks identical every single beat. But in polymorphic VT, it's a constantly shifting, changing sequence. The electrical signal isn't just coming from one rogue spot. It's this dynamic, swirling vortex of electricity. And the absolute kicker here is that this rhythm almost always deteriorates into something much worse. And that something worse is ventricular fibrillation, or VF. Guys, this is complete electrical anarchy. That swirling vortex we just talked about completely breaks down into multiple chaotic wavefronts. You won't find a single identifiable QRS complex here. The heart muscle is essentially just quivering like a bag of worms. It completely stops pumping blood, which means sudden death in mere minutes if it's not immediately reversed. Okay, let's look at a real clinical tracing to see exactly how fast disaster strikes. On the left side, you've got those regular, somewhat organized spikes. But then, right in the middle, boom, a single rogue beat, a premature ventricular contraction hits at exactly the wrong millisecond. Instantly, the whole rhythm collapses into the chaotic, jagged squiggles you see on the right. That is ventricular fibrillation. That's the exact moment the heart stops pumping. Section 2. Acute ischemia in MI. Heart attacks. Let's examine our first major suspect. A structurally damaged heart is incredibly vulnerable. Did you know roughly 10% of acute heart attack patients develop a VT that degenerates into VF? And that risk is astronomically high in the very first hour. Why? Well, as heart tissue literally dies from a lack of oxygen, it creates this border zone of injured, electrically unstable cells. This damaged tissue conducts electricity at different, sluggish speeds, creating the perfect loop, or re-entry circuit, for electricity to just chase its own tail. On top of that, surviving Purkinje cells, the heart's specialized wiring, can just start firing all on their own, kicking off that deadly polymorphic VT.
Section 3. Long QT and torsades, electrical delay.
But what if the heart looks structurally perfectly normal? Sometimes, the danger is a microscopic delay in the heart's electrical reset phase, what we call a prolonged QT interval. When the heart takes too long to recharge, it's a sitting duck for a very specific type of polymorphic VT called torsades des points. Translated from French, that literally means twisting of the points. And it gets that name because the QRS complexes look like they're twisting around the baseline, waxing and waning. It's often compared to a classic ballet sequence, pretty poetic name for such a lethal rhythm, right? And clinically, it's classically triggered by a long, short pause in the heartbeat. So how does this play out in clinical reality? Well, a patient can end up with this dangerous electrical delay in one of two ways. They either acquire it or they're born with it. The acquired form is super common in hospitals. It usually happens when patients have low potassium or magnesium, or if they're taking certain meds. Think antiarrhythmics like sotalol, antipsychotics like haloperidol, or methadone. Congenital long QT, on the other hand, is simply a genetic hand you're dealt at birth. Let's break down those exact genetics. The main culprits here are mutations in specific microscopic doors on the cell surface called ion channels. If you look closely, long QT syndromes 1 and 2 are caused by mutations in the KCNQ1 and KCNH2 genes. These essentially cripple the potassium channels responsible for letting the heart reset. Then you've got long QT3 involving the SCN5A gene, which messes with the sodium channels. Together, just these three specific genetic glitches account for a staggering 80 to 90% of all congenital cases. That is massive. Section 4. Brugada syndrome and CPVT, genetic assassins. This brings us to some other invisible genetic assassins, starting with Brugada syndrome. This is a truly fascinating and terrifying condition. It's heavily linked to that exact same SCN5A sodium channel mutation we just talked about. But instead of prolonging the entire heartbeat, it causes a localized electrical mismatch specifically in the right ventricle. On an ECG, this shows up as a bizarre coved ST segment elevation in leads V1 through V3. And here's the scariest part. It predominantly strikes men, completely out of the blue, often while they're just sleeping, or sometimes triggered by something as simple as a fever. Now, contrast that sleep-induced brugada with CPVT, or catecholaminergic polymorphic VT. The core issue here isn't sodium or potassium, it's all about calcium. Mutations in the ryanodine receptor or calsequestrin 2 genes totally disrupt how heart cells store and release calcium. So when these patients get a sudden surge of adrenaline, say from exercising or extreme emotional stress, their calcium handling goes completely haywire. This triggers a highly lethal bidirectional or polymorphic VT. Tragically, this condition frequently strikes otherwise totally healthy-looking kids and young adults right when they're at their absolute most active. Section 5. Hypertrophic cardiomyopathy, structural disorder. Let's shift gears to a condition you can actually see on a scan. Unlike those invisible electrical bugs, HCM physically distorts the heart muscle. It affects roughly 1 in 500 people, and it's characterized by a massively thickened ventricular wall. We're talking sometimes over 3 centimeters thick. But it's not just thick. At the microscopic level, the muscle fibers are in profound disarray. They are disorganized and fibrotic, creating literal physical roadblocks for electrical signals. This chaotic muscle architecture is exactly what makes HCM a leading cause of sudden cardiac death in people under 35. Section 6. Life-saving management, medical defenses. All right, so what do we actually do about all this? When these chaotic electrical storms strike, time is muscle and time is brain. The immediate emergency protocol demands physical action. The absolutely critical first step for an unstable patient or someone in VF is a 200-joule biphasic electrical shock. We literally have to hard reset the heart's electrical grid. If the storm keeps raging, we push IV antiarrhythmics like amiodarone or lidocaine. And this is key. If we recognize that twisting torsades de pointes rhythm, we rapidly push IV magnesium sulfate to stabilize those resetting cell membranes. Once the immediate crisis is averted, we have to build some daily armor to protect these patients long-term. For genetic conditions like long QT and CPVT, non-selective beta blockers like Natadol are absolute game changers. They blunt those dangerous adrenaline spikes that trigger the arrhythmias. Patients also have to strictly avoid any offending drugs. For heart attack patients, emergent revascularization, meaning opening up that blocked artery, is vital to stop the dying tissue from sparking. And if those rogue electrical pathways keep firing, electrophysiologists can go in with catheters and literally burn away the bad tissue in a procedure known as ablation. But let's be real, sometimes medications and ablations just aren't enough. Enter the ultimate fail-safe, the implantable cardioverter defibrillator, or ICD. This is a brilliant piece of technology. It's essentially a miniature computer implanted right under the skin with wires feeding directly into the heart. It watches the heart 24/7. If a chaotic rhythm like VF ever dares to return, the ICD detects it in seconds and delivers a life-saving internal shock. It is the definitive secondary prevention for survivors of sudden cardiac arrest and a vital everyday shield for folks diagnosed with high-risk genetic profiles. Which brings us to our final thought for this explainer. Just look at the immense progress we've made. We can now map the specific genes that build our ion channels. We have devices that literally stand guard inside the chest, ready to restart a stalled heart in a matter of seconds. So the question we want to leave you with is this. With all these incredible tools at our disposal, are we finally entering an era where sudden cardiac death goes from being a tragic, unpredictable mystery to a fully predictable and completely preventable disease? Thanks for learning with us today.